Hey, hi everyone. This is Dr. Shafazan talking. I'm the FTS Sleep Pillar Chair, and I wanted to welcome you to this session of FTS. Just wanted to do a little bit of housekeeping first before I introduce our speaker today. As you know, it's the topic today is going to be controversies in sleep disorder breathing with Dr. Babak Mokhlesi from University of Chicago. Next week, there is Dr. Owen from San Diego, University of California, San Diego, who's going to be talking about non-CPAP treatments for sleep apnea. And this is the QR registration code for that, so that you guys can go ahead and get registered for that. There's one final webinar of the ATS Adult Workshop series by Dr. Black, and it's going to be offered on Tuesday, July 28 at 4 p.m. This is the QR code for that, and it's on neurocritical care emergencies. So we also would appreciate it after this webinar if you could complete the webinar evaluation. It only takes a few minutes, but it will help us enhance and improve upon the sessions for next year and for your colleagues next year. There is, if you missed any of these adult sessions, FTS adult sessions, we are archiving recordings on the ECP Virtual Hub, and the code for it is here. And I think these were also provided as links for you guys. And I'm going to stop sharing and ask Dr. Mokhlesi to share his screen. And as he does that, I'm going to introduce him to everyone. So Dr. Mokhlesi, if you want to share your screen.
Can you see it now or?
Not yet, no.
Oh, okay. Let's see. All right. Share screen.
There we go, it's coming up. Okay.
Yeah.
Okay, so it's with great pleasure that I am introducing Dr. Babak Mokhlesi to you. He is the professor of medicine at University of Chicago in the section of pulmonary and critical care medicine, director of the Sleep Disorders Center there, as well as the director of the Sleep Fellowship. So if any of you guys are interested in sleep medicine, following your pulmonary and critical care fellowships, he's a great person to know. He has done great work and research and published in many areas related to sleep disorder breathing, including in the CPAP adherence and the treatment of obstructive sleep apnea and the cardiometabolic consequences of obstructive sleep apnea, OSA and REM, and obesity hypoventilation syndrome. He's a good friend and colleague, and I've always learned a lot from him. So I'm looking forward to this talk. And for everyone, it is important that if you have any questions, you could either write it in the chat. I'll be monitoring the chat, or at the end of the session, there's going to be an opportunity for you to raise your hand and ask the question directly, either one that you're comfortable with. That's great. So Dr. Mokhlesi, thank you for taking the time to give us this talk, and it's all yours.
Thank you so much, Shireen. And I want to thank you and the organizers for inviting me again this year. It's always fun to participate in these FTS sessions. So without further ado, my task is to go over some controversial areas in sleep disorder breathing with you today. And these are the objectives of the talk. Go over home sleep testing and its indications, understand the benefits of CPAP therapy, and review very briefly non-CPAP treatment indications for OSA, but Bob Owens is going to cover that as Shireen was talking about earlier. And also discuss briefly treatment options for patients with obesity hypoventilation syndrome, because as pulmonary and critical care fellows, you're going to deal with those patients as well. So let's start with a case study. A 51-year-old man with excessive daytime sleepiness, falling asleep multiple times at work. So this is pretty significant level of sleepiness, and very loud snoring and disruptive snoring with hypertension and gout. And you can see from his height and weight, he is severely obese with a big neck. And you can see all these risk factors that I'm highlighting for you. in this particular patient. So when it comes to screening your patients for obstructive sleep apnea, particularly if you have symptomatic patients, there are a lot of questionnaires out there for people to use, validated questionnaires, but a lot of people have gravitated slowly towards the stop bang questionnaire mostly because it is for simplicity and its parsimonious approach. You can see it has 8 questions and the answers are yes or no, essentially. The only things that the patient cannot answer, I suppose, would be the BMI and neck circumference, as you can see there. This was developed by Francis Chung in Canada at the University of Toronto to screen patients in the pre-op clinics. But since then, since this description more than 10 years ago, it's been pretty widely used in a variety of settings, including primary care and whatnot. And as you can see from our case, this individual that I presented has many risk factors. In fact, out of the 8 questions, he scores positive for 7 of them, as you can see. His sex, daytime sleepiness, loud snoring, hypertension, obesity, big neck. So, and one of the things initially what was described with his questionnaire was that if the score is 3 out of 8 or higher, is considered positive. But over the years, we've learned that the more points you get on it, the higher chance you have of having more clinically relevant sleep apnea. As you can see here, if you have scores of 3 or 4 and keep going up, the risk for moderate to severe or just severe OSA keeps going higher. So I think a lot of people now are focusing on higher questionnaires just to weed out people who may have milder forms of sleep apnea. So in our case, this individual who had 7 out of 8 questions positive would be around 80% probability of severe sleep apnea, obstructive sleep apnea. So here's our first poll question. What should be the next step in the management of this sleepy patient? So maybe we'll give, I don't know if Liz, you can activate the poll. There you go. So you have 4 options. We'll give you a few seconds to think about, and then we go from there. We need some Jeopardy music. So I'm from Chicago. You can vote frequent and often here if you want. All right, so good. So 64% got the right answer. Order a home sleep apnea test. Let me go to stop share. How do we get out of this now? Oh, just click on this. Okay. So the correct answer is order a home sleep apnea test. And the reason behind it, well, before we go into that, I'll just share with you who that individual was that I described. This was our 27th president. If you one day have extra time on your hand, I recommend you read this paper by Sotos in Chess in 2003, which gives very nice description of the life of Howard Taft and how his obesity and daytime sleepiness created problems for him during his presidency. But this is his career. You can see with the arrow here, this is when he was elected president of the United States. And his BMI, his weight actually kept going up. You can see at his peak, he was around 340 pounds. And that's when he was falling asleep during meetings and people in his cabinet were complaining. And eventually after that, you can see his weight dropped very, very significantly, almost 100-pound weight loss. This is before gastric bypass surgery, obviously. So he just did it with, serious dieting. And at this point in his career, when he became Chief Justice, he was completely alert without any problems. So, and not only that, with that much weight loss, his blood pressure dropped dramatically. So this is before the era of HIPAA, I suppose. So one question that comes up, and there was some controversy about this a few years ago, was whether people should screen patients in your clinics for sleep apnea. And as I said earlier, there are a variety of tools out there to screen, questionnaires. the most common ones, for example, the stop-bang questionnaire that we discussed, or the Berlin questionnaire. And these questionnaires are really designed to have a high negative predictive value. So they're highly sensitive, but not very specific. And the important thing to understand is that they're designed in a way that they're not trying not to miss anybody and capture a lot of people. And so if the clinical suspicion is high and the questionnaire is negative, for example, we recommend to move forward with the diagnostic testing. The reason I said there was some controversy around this was a few years ago when, in JAMA, the United States Preventive Services and Task Force published, went over the evidence essentially and reaching the conclusion that there's not enough evidence to suggest to clinicians to routinely screen patients who are asymptomatic for obstructive sleep apnea using these type of questionnaires. And it stirred some controversy in the field. A lot of sleep docs thought that's the wrong recommendation. I kind of personally agree with the recommendation of the United States Preventive Task Force, because it's just there's not enough evidence that if you do these screenings leads to any major changes in patient outcomes. If that's the focus, improving patient outcome as opposed to just making diagnoses. So with that said, I want to share with you this slide, and probably I could have updated it even more for this talk, but the point is the same. The point I'm trying to show you here is over the years, you can see that once Medicare and Medicaid services approved home sleep testing back in 2008 or so, many insurances followed suit after Medicare, and you can see how home sleep testing for sleep apnea has increased significantly. Now, the volume of sleep labs has gone down, but not dramatically. I think what's happened is the home sleep testing has allowed more patients to get tested, not necessarily replacing all patients coming to the sleep lab. And in a nutshell, respiratory home sleep testing consists of, there are few technologies out there. Most commonly is this respiratory polygraphy. So if you notice the somno, the sleep is not there. So for example, you have measures of flow of air from a nasal pressure cannula and a thermistor flow sensor. You have measures of effort from chest and abdomen, so you can distinguish between obstructive and central apneas. And you have oximetry and pulse rate. And some of the devices allow you to even measure leg movements. But again, there's no measure of sleep per se. So respiratory polygraphy seems like an appropriate name. Another device out there that a lot of people use is this device called WatchPAT. PAT stands for Peripheral Arterial Tonometry. It's an interesting technology because you don't have anything on your nose measuring flow of air, and there's no belts on your chest and abdomen measuring effort, which begs the question, well, how would the device know if somebody stops breathing or there's no flow of air or reduced flow of air at the nose to score hypopnea? So the device uses a validated algorithm looking at how respiratory events lead to arousals, and arousals, e.g. microarousals, lead to sympathetic surges, and that clamps down your arterial tone. And looking at these and oximetry, it can kind of indirectly measure respiratory events. Now, in terms of going back to our question, the case that I presented was the hypothetical case, which was actually the president, ex-president, is a case where the clinical suspicion for severe obstructive sleep apnea is very high. And in those situations, it makes sense not to waste time or money and go with a home sleep testing using a portable monitoring device of whichever type. And these studies are obviously unattended. It does require cognitive and manual dexterity in your patients. So occasionally we run into issues with technical difficulties. So depending on which study you look at, 10% or so of the studies, 15% of the studies have technical issues. It's less sensitive than in-lab polysomnograms, but in a patient who has very severe sleep apnea, it may not matter. In patients who have very, very mild sleep apnea, then you may miss it. And in most of the studies that looked at this technology, they tried to exclude individuals who had a lot of cardiopulmonary issues or other primary sleep disorders like severe insomnia or narcolepsy, periodic limb movement disorder, those kind of things. Undoubtedly, they're cheaper, as you can see, compared to a polysomnogram, which may cost $800, $900. And I think if done correctly, it could be a good tool to be used by non-sleep docs, as long as it's implemented accurately and correctly. So here you can see the two devices. This is the respiratory polygraphy, and this is the watchpad device. Again, there are other technologies out there. I'm just giving you two examples. So the reason the Center for Medicare and Medicaid Services approved home sleep testing back in 2008, 2009 was because evidence was mounting that when patients are randomized to coming to the sleep lab, undergoing a polysomnogram, undergoing CPAP titration in the sleep lab versus home sleep testing and maybe getting an auto CPAP device, that the outcomes were not that different and it was more cost effective. So you can see I've listed a few studies here and have been published looking at effectiveness of home sleep apnea testing compared to polysomnography. So many of these studies included individuals who had high probability of moderate to severe OSA. These individuals were typically complaining of hypersomnolence, and they had typically no significant comorbidities like the ones listed here. And what they found in these clinical trials was that regardless of which path you took, home sleep testing followed by auto PAP versus in-lab polysomnogram and in-lab CPAP titration, there was no difference in patient outcomes. There was no difference in the level of CPAP adherence down the road, and there was no difference in patient satisfaction, and it was actually cheaper, which is not surprising. The cheaper part is not surprising. So based on this emerging data, the American Academy of Sleep Medicine updated their clinical guidelines for home sleep testing back in 2017. And several recommendations that they gave was we should not be using screening questionnaires to diagnose obstructive sleep apnea. So screening questionnaires like the Stop Bang or the Berlin or other questionnaires out there are, as the names imply, screening tools. They're not there for making a diagnosis. At the end of the day, if there's a clinical suspicion for sleep apnea in somebody who's, for example, symptomatic, then you need a diagnostic test, and the options are polysomnogram or home sleep testing. And for individuals, the American Academy of Sleep Medicine recommended that for individuals who have significant cardiorespiratory disease, neuromuscular conditions, or concern for hypoventilation, chronic opioid medication, etc., to come to the sleep lab as opposed to home sleep testing. So the individual that I presented earlier really didn't have any of these risk factors. So I think a home sleep test for somebody in whom you have a high clinical suspicion for significant OSA made sense. Now, another area that created some controversy in the field was, comparing outcome of patients when patients are managed by primary care docs or providers versus sleep providers. And here are, I'm not doing justice to these studies, but just summarizing for you two clinical trials, one from Australia that was published in JAMA, and one from Spain, which was published in the Blue Journal not long ago. And you can see that both studies showed that if the primary care docs and providers are somewhat trained and they follow certain protocol, there's no difference in patient outcomes as it pertains to quality of life, improvement in sleepiness, blood pressure, CPAP adherence, and both studies showed that it was more cost effective. Here's an Australian trial where patients were randomized to being managed by primary care versus sleep docs. As you can imagine, back in 2010 to 2013 when the study was done, most of these patients referred to the sleep docs were undergoing polysomnography in the lab. In this model, in the primary care model, there was a nurse who was trained and spent time in the sleep clinics to understand how the process works. But most of these patients underwent home sleep testing followed by auto PAP. And you can see that there was no major differences between the two groups in terms of sex, age, obesity and whatnot. And the severity of oxygen desaturation index, a marker of obstructive sleep apnea, was not that different between the groups either. But at the end, at 6 months, when you look at daytime sleepiness, improvement in daytime sleepiness measured by the Epworth Sleepiness Scale, quality of life, or blood pressure, none of these reached statistical significance between the two arms, whether the patient was managed by primary care or by sleep specialist. And of course, not surprisingly, management by sleep specialist was more expensive than being managed by primary care. And a lot of that was driven by polysomnography, because the sleep docs were ordering more in-lab studies, consultation fees, and traveling, because in Australia, sometimes when you want to go to a specialized sleep center, they may not be available in rural areas. But what's interesting, if you look at the minor details of the study, the sleep specialists were actually more likely to prescribe non-CPAP therapies, and less patients withdrew from the study when they were under the care of sleep specialists, and there was less discontinuation of CPAP when the patients were being managed by sleep specialists. So with that said, the bottom line was that primary care providers can do a fine job in uncomplicated patients, as long as they receive some training like they did here and follow certain protocols. But if we just kind of allow from this study that everybody orders a home sleep test without any further training, you can see how it could be problematic. So let's do another question. A 55-year-old woman is referred to you because she underwent a home sleep apnea test and was diagnosed with moderate obstructive sleep apnea with an apnea-hypopnea index, or an AHI, of 20. Complaints that led to this test were loud snoring, witness apneas. She was also recently diagnosed with hypertension, but is currently not taking any pharmacotherapy for it. She's obese, obviously hypertensive, and she reports habitually sleeping around 6.5 hours per night. So not a lot of, short sleep there, and denies excessive daytime sleepiness, but complains of daytime fatigue. So the question is, which of the following recommendations will be the most likely to improve her long-term cardiovascular outcomes? So maybe Liz, you can start the second question. So you have 4 options. So do we start CPAP to normalize blood pressure? Do we extend sleep to 8 hours per night instead of 6.5 hours? Start oral antihypertensive to normalize blood pressure, or treat obstructive sleep apnea with CPAP to improve daytime symptoms in order to facilitate weight loss? All right, so we got a variety of answers there. So let's see, let me close this. So in my opinion, the right answer is start oral antihypertensive therapy to normalize blood pressure. Now, the reason, again, I'm showing this is because, as the topic of the talk implies, is controversies now in sleep disorder breathing. So if you notice, option A says start CPAP therapy, normalize blood pressure. With a blood pressure of 155/95, it's highly unlikely that CPAP will drop it that much, and I'll show you some data. Extend sleep to 8 hours per night. She's sleeping 6.5 hours per night. So it's not awesome, but it's also not horrendous. So I think extending it to 8 hours, you're not going to get that much bang for your buck as it pertains to blood pressure. And treating obstructive sleep apnea with CPAP to improve daytime symptoms in order to facilitate weight loss. Well, remember, she was not that symptomatic to start with. She was not complaining of daytime sleepiness. And believe it or not, CPAP usually doesn't make people lose weight. In fact, most studies have shown that people, when they go on CPAP, they may gain 2-3 pounds compared to like placebo CPAP or sham CPAP. So here is a meta-analysis published in JAMA 5 years ago, where you can see there have been 47 trials up to 2015 with total sample size, as you can see here, of patients, where individuals were randomized to CPAP versus usual care, inactive control. And you can see that CPAP is statistically significant. The drop in blood pressure with CPAP is statistically significant, but it's not a huge effect size. So you can see here that on average, depending on which study you look at, the blood pressure drops by 2-3 millimeters of mercury, roughly. And again, I'm not trivializing it. I think 2-3 millimeters of mercury drop in blood pressure can have, in a public health scale, can have an important impact. But an individual patient, I think that's not going to cut it for this patient. Here's an example of a study that was published now 10 years ago by a good friend of mine in France, Jean-Louis Pepin. And you can see here, it was a nice study because it's a small study, but it proves an interesting point. 23 hypertensive patients, recent diagnosis of hypertension and recent diagnosis of obstructive sleep apnea. And what the team did is they randomized them to either CPAP first or valsartan first. And then they had a washout period and they randomized them to the other arm. So it was a crossover trial. So each individual did both arms. And if you look here, here's your baseline blood pressure throughout the day with ambulatory blood pressure monitoring. And here's your valsartan. A significant drop after 4 weeks of valsartan. And both systolic blood pressure and diastolic blood pressure. This is CPAP. You can see that the drop in blood pressure with CPAP is not as robust as it is with antihypertensives. So going back to the case that I presented, if you have a patient who comes to the clinic and has severe sleep apnea or moderate sleep apnea and also has hypertension, I think it's important is incumbent upon us to make sure the patient uses their antihypertensives as much as they can so they can normalize their blood pressure to reduce future cardiovascular risk. Now, here is a paper also from JAMA from 2012 from the Spanish Sleep Network. And what they did here is they took non-sleepy patients with obstructive sleep apnea, and their goal was to prevent hypertension or cardiovascular disease over a period of 4 years, median follow-up 4 years. And you can see decent sample size, people randomized to CPAP or usual care. And what they found was that in the CPAP group, 68 patients who were diagnosed with new hypertension and 28 patients with cardiovascular events. In the control group, the numbers were not that dissimilar. So at the end of the day, the difference between CPAP and control for the cumulative incidence of, be it new incidence of hypertension or new cardiovascular events, was not different. However, when you categorize people on this is the intention to treat, but per protocol analysis, if you look at those who are actually adherent to CPAP, using it more than 4 hours per night, versus those who didn't and controls, you can see that cumulative incidence of cardiovascular events went down in those who were adherent to therapy. Now, another study from the Spanish Sleep Network looked at the question of resistant hypertension. So these are individuals who have significant OSA with an apnea-hypopnea index of 40, taking close to 4 antihypertensives, and they're still hypertensive. And what they did is they randomized them to either CPAP or usual care. And what they found is that CPAP dropped blood pressure by around 3 millimeters of mercury for systolic and also 3 millimeters of mercury for diastolic. One thing they did note here at the bottom of and in this figure, you can see that nocturnal dipping of blood pressure, which is normal and supposed to happen, increased significantly. At baseline, in these individuals with resistant hypertension, a quarter of them were having nocturnal dipping, which is normal, where your blood pressure drops at night. And with CPAP therapy, it increased by 10 percentage, meaning 10% more people became dippers, which is good. In the other group, there was no difference. So, and being a dipper in terms of your blood pressure and heart rate at night, when your blood pressure and heart rate drop by at least 10%, it confers better outcomes for patients in terms of cardiovascular outcomes. Now, this brings us to the largest clinical trial in our field, which was published now 4 years, the Sleep Apnea Cardiovascular Endpoints, or the SAVE study in the New England Journal of Medicine, is a multi-country, multi-center RCT. And this is the largest clinical trial in the field of sleep medicine. So you can see the numbers, randomized to CPAP versus usual care. These are individuals who have history of cardiovascular disease, and now they're being randomized to CPAP versus no CPAP if they have OSA, to see if they can prevent subsequent cardiovascular events. So it's secondary prevention, if you think about it. But they excluded people who are very sleepy if their Epworth sleepiness scale was above 15. And just to give you perspective, the Epworth sleepiness scale is a scale of 0 to 24. And scores above 10 are considered sleepy in clinical practice. So they went above 15, they excluded those individuals. The highest score you can get is 24. They excluded people who have significant hypoxemia during sleep and people who had resting hypoxemia or significant COPD. At the end of the day, there was no difference in cardiovascular endpoints after several years of follow-up. However, the patients who were randomized to CPAP did feel improvement in quality of life, mood, and work productivity, but that was not the primary outcome. The primary outcome was cardiovascular endpoints, and that did not show any difference. And here is the final kind of graph showing that the two arms, CPAP versus usual care, looking at cumulative incidence of cardiovascular events, there was no difference. And you can see that over the years, these months of follow-up, CPAP adherence, how many nights were they using, how many hours they were using it per night, did go down, but it kind of plateaued around 3 to 3.5 hours per night. So not awesome CPAP adherence. And that was one of the critiques of the study, that a lot of patients were not using their CPAP. However, when you look at the online supplement of this paper in the New England Journal of Medicine, and it's close to 150 pages, you'll find this figure that I think is quite revealing. So here they looked at patients who were randomized to CPAP and used it. That's the orange line or yellow, whatever that color is. Red line were people who were randomized to usual care, meaning they're not on CPAP. And the blue line are people who were randomized to CPAP, but they didn't use it. They had poor adherence. And you can see that those who had poor adherence are the ones who died more or had more cardiovascular events. But those who were randomized to CPAP and actually used it, their outcomes were no different than people who were randomized to usual care. So I think what this shows us is people who are non-adherent to therapy tend to have bad prognoses. But it doesn't show that if you're adherent to CPAP, you have reduction in cardiovascular events, which was somewhat disappointing and steered a lot of controversy in the field. And one of the controversies was that a lot of the patients that were enrolled in this clinical trial are not the typical patients that, for example, we see in sleep clinic who are very sleepy, and they excluded people who had significant hypoxemia at night due to sleep apnea. So be that as it may, at the end of the day, you can see the results that pushing CPAP as a treatment to prevent the following cardiovascular event, meaning secondary prevention, the data suggests that there's no robust evidence that to support that. So let's do question number 3. The same lady we did in the last question, 55-year-old woman who had, the question was whether we should give him antihypertensives or not, decides to start treatment for OSA to decrease snoring and witness apneas. Now, she didn't have a lot of daytime sleepiness, but she wanted to start CPAP because her husband would not sleep with her in the same room. And she undergoes a brief trial of, mask fitting and CPAP in the clinic, not in the sleep lab, just so she gets a feel for it. And, she just felt like this is too much. She won't be able to handle it. So which of the following recommendations will be the most accurate in the treatment of OSA, both in this patient and any patient? So maybe we can start the poll here. So the options are: CPAP has greater efficacy than mandibular advancement devices in treating obstructive sleep apnea. Mandibular advancement device has lower clinical effectiveness than CPAP for mild to moderate OSA. Referral to ENT for hypoglossal nerve stimulator. And again, this is in the context of somebody who doesn't like CPAP. or uvulopalatopharyngoplasty, or UPPP, is more effective in treating OSA than CPAP in this patient? Okay, let's give a few seconds here. Okay, so good. We got some a good spread of results. So let's go over the answer here. Okay, so the answer is CPAP has greater efficacy than mandibular advancement device in treating OSA. Just to go over this for a second. So CPAP is more effective. In other words, if I have somebody who has an AHI, apnea-hypopnea index of 40, which is considered severe OSA, and I put them on CPAP, in most scenarios, I can get that individual with CPAP to an apnea-hypopnea index of close to 0. So it's more effective than oral appliance. The problem is that if a patient is going to tell you that I can't use CPAP, you can have a highly effective therapy, but if they're not going to use it, its effectiveness, clinical effectiveness goes down. So oral appliance is less efficacious than CPAP, but if an individual uses it more, it ends up having a higher clinical effectiveness. So the lower clinical effectiveness is inaccurate here. It's actually higher clinical effectiveness merely because the individual would use it more because they find it easier to tolerate, for example. So CPAP, it almost sounds like I'm, so far saying that CPAP is useless, but I'm putting a plug here for CPAP. There's overwhelming evidence. I'm not sharing all the overwhelming evidence because we're talking about controversies here, but overwhelming evidence from RCTs that when you compare CPAP to sham or placebo CPAP, CPAP improves daytime sleepiness, snoring, quality of life, including that of the bed partners, improves sleep disorder breathing by improving hypoxemia during sleep and reducing AHI and improving sleep fragmentation. Also decreases motor vehicle accidents, occupational accidents. So there's overwhelming evidence that CPAP actually helps people. So not everything is, cardiovascular events. There's a lot of value in making people feel better. And CPAP definitely does that as long as the patient can tolerate it. That means there has to be options for patients who cannot tolerate CPAP. As a joke here, in equine medicine, not everything has to be CPAP, CPAP, CPAP. We have to give options to people. And so this is kind of like a good prelude to Bob Owen's talk in a few weeks about non-CPAP treatment options for patients with obstructive sleep apnea. So I'm not going to talk about it now because he will cover this. But mind you, CPAP is not the only option. And since we were talking about oral appliance, that case that we discussed, that woman who said, I cannot tolerate CPAP in the clinic, she would fit nicely into this clinical trial from Australia where patients were randomized to either CPAP or oral appliance, and and then they crossed over to the other arm. So each person did both arms. So you can see in terms of efficacy, you can see that CPAP can drop the apnea-hypopnea index more effectively than oral appliance. So has greater efficacy, but people use it less. Adherence tends to be lower. Therefore, clinical effectiveness sometimes favors oral appliance. But in this clinical trial, patients that tried both arms, these 108 patients, you can see that there was no difference in Epworth Sleepiness Scale, quality of life, or change in blood pressure. None of these reached statistical significance. In other words, oral appliance so working with your dentists who have expertise in sleep dentistry could be a huge help for patients. So they have an option other than CPAP. So let's do this question now, and I think this is our last question. 60-year-old severely obese man was recently hospitalized for acute and chronic hypercapnic respiratory failure, was successfully treated with NIV during the ICU stay, and was discharged from the hospital 6 weeks ago and is now following up in the pulmonary clinic. He complains of hypersomnia and shortness of breath with exertion. He is hypertensive and has gout. On exam, his blood pressure is somewhat elevated. He's severely obese. His oxygen saturation on room air while resting and talking to you is 93%. He's a little bit tachypnic, and he undergoes office spirometry, and you notice that he has mild reduction in FVC, but the FEV1 is normal and the FEV1 to FVC ratio is normal. A room air blood gas, now that he's been 6 weeks out of hospital, shows that his pH is close to balanced with mild acidemia, some CO2 retention, and mild hypoxemia. So, based on your clinical suspicion for sleep disorder breathing, you order a split night polysomnogram, which reveals severe hypoxemia during sleep. So he spends 30% of the sleep time below 90% oxygen saturation, and his apnea-hypopnea index is terrible. Above 30 is considered severe, so I suppose this is triple severe, so it's really, really bad. So the question is, you decide to initiate positive airway pressure therapy because this is just extreme, very severe sleep disorder breathing, and the patient has daytime hypercapnia and is extremely obese, and the spirometry and the chest x-ray do not suggest that there's any parenchymal lung disease or neuromuscular disorder or COPD. So you think this patient has obesity hypoventilation syndrome and severe obstructive sleep apnea. Now the question is, how are you going to treat this individual? So let's start the poll. Options are CPAP, bilevel PAP or BiPAP in spontaneous mode without a backup rate, bilevel PAP ST, that means spontaneous time, that means it has a backup rate, or volume targeted pressure support, which is like AVAPs or IVAPs or your trilogy, so to speak. Okay, so a lot of you picked BiPAP with a backup rate or bilevel PAP ST. Let me close here now. So in this case, the correct answer is CPAP, and I'll share with you why. So, and a lot of this comes from the Pickwick study, which is a clinical trial where patients with obesity hypoventilation were categorized into two big subtypes: those who have severe concomitant sleep apnea, obstructive sleep apnea, or meaning the apnea-hypopnea index is above 30, or those who have daytime hypoventilation, obesity hypoventilation, but they don't have severe obstructive sleep apnea. So you can see right off the bat, the majority of patients with obesity hypoventilation syndrome have severe obstructive sleep apnea, close to 70%. So in this clinical trial, patients were randomized to CPAP, non-invasive ventilation, and when I say non-invasive ventilation, all these option B, C, and D are considered non-invasive ventilation, with C and D being fancier modes because you have a backup rate or volume target. CPAP is not non-invasive ventilation. So, and then after 2 months, since they thought it would be unethical to leave these patients on lifestyle modification, these 71 people were randomized to these two groups, and they were followed over 3 years. And I'm gonna skip this slide. The results were published. We published the results last year in Lancet. So the median follow-up was 5.4 years. The average CPAP pressure was around 11, and the median usage was 6 hours per night. The folks who got randomized to non-invasive ventilation, they were getting volume-targeted pressure support, and the average pressures they were getting was 20/8. That means 12 of pressure support, and the delta between IPAP and EPAP, with a backup rate of 14 breaths per minute. And the average usage of NIV was 6 hours, not that different from CPAP, as you can see. And the primary outcome was hospital days, meaning if they get hospitalizations. And those then were not different between the two arms. We also looked at incident cardiovascular events, 15% for CPAP, 17% for NIV. Again, no significant difference. And in terms of death, 15% of the people randomized to CPAP over 3-4 years versus 11% in NIV died. Again, this didn't reach statistical significance either. So you can see here probability of survival in this Kaplan-Meier, no difference. However, if you look at people who are adherent, NIV use more than 4 hours per night or CPAP more than 4 hours per night, no difference. So if you're adherent, regardless of which arm you get randomized to, you do well. If you're non-adherent to either CPAP or NIV, you don't do as well. And this is, again, survival curve. So, and the adherence were fairly similar between the two arms. What we also notice is that there's a significant drop in dyspnea over time. This is no difference between CPAP or NIV. So dyspnea went from 63% to 27% over time, CPAP 54 to 33%. And both therapies, both CPAP and NIV, led to improvement in daytime oxygenation, leading to discontinuation of supplemental oxygen. So in CPAP, 27% at baseline were prescribed oxygen on top of CPAP, which went down to 13% at the end of 3 years. And in non-invasive ventilation, 22% required oxygen and went down to 11%. Both of them were significant. So the question that comes up is, well, when should we consider NIV in people with obesity hypoventilation syndrome? So naturally, when your patients are admitted to the emergency department or ICU with decompensated acute on chronic hypercapnic respiratory failure, they should be on non-invasive ventilation, not CPAP. If an individual with obesity hypoventilation syndrome undergoes polysomnography and they don't have significant sleep apnea, so they're like your pure hypoventilators, so to speak, then in those instances, giving them CPAP seems not appropriate. They would require non-invasive ventilation. If you decide to follow the path of the data that I just showed you, and you put them on CPAP, and the patient is adherent to CPAP, but clinically they don't improve, be it their blood gases don't improve or they're remain very symptomatic, then I think it's worthwhile switching them to another modality like non-invasive ventilation and see what happens. So I think these are situations when one would consider non-invasive ventilation over CPAP. So to conclude, and then I'll open it up for questions, OSA is a prevalent condition in the community. Some studies have suggested that close to 40, 50, 60%, depending on which study you read, of people can have obstructive sleep apnea. Middle-aged people can have obstructive sleep apnea. The problem is that finding all those individuals who are asymptomatic and treating them at this point is probably not necessary. Mostly because the data suggests that CPAP makes people feel better. So if somebody already feels fine, what's the point of diagnosing them and giving them CPAP? You see, that's why the United States Preventive Task Force recommended not screening asymptomatic people for obstructive sleep apnea. Mostly because the data suggests that CPAP is highly effective in improving people's quality of life and symptoms when they have problems. And the point here is that up to 40, 50% of people with severe obstructive sleep apnea on polysomnography don't have symptoms, don't complain about anything. So, and that's a challenge. What do we do with those patients at this point? CPAP reduces blood pressure by 2-3 millimeters of mercury. But again, antihypertensives are significantly more effective than CPAP. So although I always encourage my patients to increase CPAP adherence, the bottom line is that if somebody's blood pressure is out of control, pushing CPAP is not going to cut it. And pushing antihypertensives, I think, is the appropriate thing to do to overall decrease the risk of future stroke, myocardial infarction, end-stage renal disease, so on and so forth. Oral appliances are quite effective. And if done well, together with folks who have expertise in sleep dentistry, patients can feel a whole lot better. And some patients may use it much more than CPAP. And that's why in those individuals who use the oral appliance more than CPAP, in that individual, then oral appliance has higher clinical effectiveness, even though CPAP may be more efficacious. But if it's efficacious and that patient doesn't use CPAP, then what's the point? And then in my last conclusion here is that the role of CPAP to improve cardiovascular morbidity and mortality is a moving target. The largest clinical trial that I shared with you, the SAVE trial, suggested that at this point, there's no hard evidence that it improves secondary prevention of cardiovascular disease. But, I think, maybe more research is needed in that area. So with that, I'll stop and I'll be happy to take any questions. Thank you.
Thank you, Babak. That was a great talk. And so right now what you can do is either type your questions in the chat area so that I can ask them for you, or you can raise your hands and around the participants area, you can click on raise your hand and you can ask your questions directly. There was a question in the chat area already that says, can you please repeat the answer for question 2?
Let me remember which one was question 2. Question 2 was, I'm bringing it here. Hold on for a second. Let me share my screen again. So if this was the woman who was referred for, she had home sleep testing because of snoring and witnessed apneas and was found to have moderate OSA. And she reports sleeping 6.5 hours, but denies daytime sleepiness, complains of some fatigue. And let's see, what did we say next? And then we said about long-term cardiovascular outcomes. What would be the best intervention to improve long-term cardiovascular outcomes? So CPAP therapy improves blood pressure, but the effect size is small. It's like 2-3 millimeters of mercury. So for example, somebody who has a blood pressure of 155/95, it's highly unlikely that CPAP is going to normalize their blood pressure. Extending their sleep to 8 hours from 6.5 hours also is highly unlikely to normalize their blood pressure. And the goal here is understanding what can improve her cardiovascular outcomes. There is overwhelming evidence in the literature from the 1960s till now showing that the more you drop people's blood pressure without them getting side effects, the longer they live and the less problems they have. The last study was a sprint trial that was published in New England Journal of Medicine several years ago, where they pushed for even more aggressive drop in blood pressure with additional antihypertensives, and people got less strokes, died less. So I think the jury is in. We need to normalize people's blood pressure, and CPAP can drop the blood pressure, but it's difficult to normalize it when your starting point is so high like this patient. In terms of the last point I made here, treatment of OSA with CPAP to facilitate weight loss, again, initially years ago we used to think like, okay, go on CPAP, you'll have more energy, maybe you'll exercise more and you'll lose weight. But when you look at clinical practice and data from research, it doesn't pan out. Most people who go on CPAP over time, they gain weight. And the question you can pose is, are they gaining weight because of CPAP, or are they gaining weight because that's a natural history of their weight gain over time? But when you compare that to placebo CPAP or sham CPAP, in reality, they actually put on a few extra pounds, 2-3 pounds. So I would not push CPAP as a treatment option for losing or facilitating weight loss because the data doesn't support it.
Okay, thank you. What is the role of hypoglossal nerve stimulator in treating OSA? Will it replace CPAP and its adherence problems?
I think I seriously doubt it will replace CPAP because many patients don't want to undergo surgery and get an implant device in them. And moreover, the more obese the patient becomes, the less likely it is that it will work well. In the clinical trial that was published in the New England Journal of Medicine in 2014, I want to say, the STAR trial, they used a body mass index cutoff of 32 or less. Now, I don't know about the cities where you guys practice, but in Chicago, that's cachexia. So, good luck finding somebody with BMI of 32 and less in the sleep clinic. With that said, now they've changed the criteria. Many insurance providers are increasing the weight limit to BMI of 35. The reason is because the more obese you are, you also get crowding in the oropharynx. and the hypoglossal nerve stimulator by unilaterally, innervating the tongue with inhalation to move it forward, that extra space that opens up may simply not be enough to solve the problem. So, so I think for people who have extremely severe sleep apnea or very mild sleep apnea who are symptomatic, or people who are obese and cannot lose weight, they don't have that many options. The hypoglossal nerve stimulator will not work for them, and they will get excluded, and the insurances won't pay for it.
Okay, thank you. Okay, there doesn't seem to be any more questions in the chat. Does anyone want to talk or raise their hand, or are there any further questions? So I think for the fact alone that it helps with the sleep quality and the feeling of sleepiness and, to a certain extent, memory and concentration, many of us feel strongly about the use of CPAP, especially in the symptomatic moderate to severe sleep apnea. But the while there is the epidemiological data that suggests that there isn't, that there is an impact of adhering to CPAP on perhaps your mortality, unfortunately, SAVE very disappointingly did not show that. So do you think there's room for another trial, maybe to try and compensate for some of the critiques of SAVE to put this matter to the test again, or that's it? We're going to say.
Well, I always tell my fellows that my talk sounds like a downer, but I always say that, as I said earlier, CPAP makes people feel a whole lot better. So I wouldn't sell ourselves short. Our job is to make people feel better. Now, in terms of cardiovascular outcomes, I think the clinical trial that needs to be done is a study where patients who are symptomatic and have significant sleep apnea, who are enrolled from sleep clinics, people who actually are the ones who are seeking help, those are the ones who get randomized. The problem with that approach is that, because one of the critiques of SAVE trial and many other trials is that they go and look for non-sleepy patients, and they don't look for these individuals, who come to the sleep clinic seeking help. Reason is because they feel that it may be unethical to withhold therapy for somebody who's symptomatic when the data suggests that CPAP makes people feel better, withholding therapy from them for 4 or 5 years in a large, long-term clinical trial. Because for cardiovascular events, you need long-term follow-up. So, so again, I think that's where the issue is in terms of ethical issues. I don't know how we're going to overcome those ethical issues, but the best trial for me would be enrolling people who are the ones who seek help, and even if they're symptomatic, they don't get therapy. But that's a challenge, because you may be able to get away with 2-3 months of not treating them, and randomizing them to like usual care or sham CPAP, but for 4 years, I think it will be tough. So I think it'll be hard to get good evidence beyond the SAVE trial, because all studies are going to do the same approach. They're going to enroll people who are not very sleepy, otherwise they would have been excluded. So I think that's a challenge we face.
Yeah, that is true. Well, there aren't any more questions, so I really wanted to thank you for spending the time. Excellent talk. I really enjoyed it, and I hope that the audience also had an opportunity to learn a lot. This is going to be available in the archives for further viewing. And thank you so much, Dr. Mokhlesi. Hopefully we will see everyone at ATS next year.
I'll keep my fingers crossed. Thank you.
Sounds good. Thank you.
Bye-bye.
Bye, everyone.